Well, the work's about a project we did with Nepean Hospital in Sydney to develop emergency department information systems according to a new methodology that we've developed at NEDIMS. The work's the result of a lot of process analysis we've done in EDs and ICUs over many years. And the presentation today is to show how the systems development methodology works in a more dynamic way, given that it's a completely new approach. There's some theoretical presentations touched on so that people know that it's founded in some solid thinking. And there's a full scientific investigation of which will present some of the results, which we've written up into a substantial 180-page report that can be made available. But the aim is to present this methodology through this new media to give it a different vitality. Well, I think we wanted to show that work processes were as important, if not more important, than in fact the capture of data. I think secondly, we wanted to show that a better technology could be created than what existed currently in hospitals. And we wanted to show a method of evaluating in comparison to clinical information systems. And through all of that work, ultimately our faith in the demonstration prompted us to take what we've done here to market.
The ISIMS design framework consists of 7 activities that take place around the design, redesign and test cycle. The key aspect here is that designing the system can start as soon as the first requirement is defined. You don't need to define all requirements in order to start designing the system. Our technology allows the clinical design team to take charge and test different designs until they reach their ideal system. No programming is required to create the runtime system from design. The NEDIMS design is based on the core principles that the system needs to match the local workflow, meaning that it should be intuitive, increase efficiency, and reduce cognitive load. The system covers a wide range of tracking functions by patient status and/or location within the department. Different lists promote different functions based on their context. The NEDIMS homepage defaults to a tracking screen split into 3 main categories: patients to be seen, seen patients, and patients to be admitted. The motivation behind this structure is to provide a meaningful overview of the current state of play in the department rather than just a whole list of patients. Each table also has its own unique functions. For example, if a patient waiting to be seen by a doctor has been attended to by a clinical initiatives nurse, the SIN button turns green. The patient record screen is designed by clinicians with the primary focus of reducing nesting, meaning that they didn't want to do too many clicks to get to a certain screen in the patient record. It also matches the simplicity of a paper file, where you flick through pages, or in this case, tabs. The clinical team designed the main tabs to include triage, clerical, vital signs, patient care summary, clinical documentation, nurse tasks, and disposition. Below that are the key patient demographics and context, such as their presenting problem and diagnosis. The central page of the patient record is their care summary. This is a specially designed form by senior clinicians who identified the need for a clinical dashboard of the patient. It is aimed at providing a summary of all staff members who have dealt with the patient, the most recent vital signs, all the key performance indicators for this particular patient, and their current disposition status. The design of the NEDIMS system was never predetermined. In fact, it was a highly iterative approach towards the clinical team's optimal design. For example, the tracking screen demonstrated earlier went through a large number of iterations until it reached its current design. Another example is the initial nursing assessment process, which is also known as the SIN process. The original design of the form had to be replaced due to a work practice change by the ED administration. This was easily incorporated within 2 working days. Later modeling showed that the time spent in computerizing the form was recovered in time savings of clinical staff in only 6 days of usage. So one of the things when we did the time and motion analysis that we actually discovered a lot of interruptions. So a staff member would be completing a task at a terminal, gets interrupted by another staff member asking them about patient information. We noticed that in some cases those interruptions were actually costing more time than the task itself that's being completed at the terminal. So we did a side study. We actually, with the help of the clinical team, we tried to identify what were the causes of the interruptions, and the clinical team were able to come up with a list of fields per se, or basically classes of information that they always interrupt each other about in terms of patients, meaning that it's not information that's easily accessible, and they would rather actually talk to each other about that information or transfer it verbally instead of trying to find it somewhere. We designed a function that comes automatically with each patient in any tracking table in the system. This function was known as the FAQ form. The form is designed to display all information that the clinical team identified as the main interruption topics. This information is displayed as a collection of data fields. So the FAQ form was meant to be an auto-populated form, meaning it's not a data entry form at all. The assumption was that all these fields are already somewhere in the system. What happened is when we designed the form, we discovered that some of those fields are in fact not designed anywhere in the system, which confirms even further that they were reasons for interruptions. Fields such as plan and diet had to be data entry fields as they are not collected elsewhere in the system. Once the clinical team identifies where they want to capture those fields in the system, they can incorporate them where they naturally fit as part of their continuous process improvement practice.
Well, we call it emergent clinical information systems because what you get at the end of our process is not something that comes from a prescriptive process as in classical systems analysis and design, but it's an emergent system arising from the creative processes of the people who are involved in design. The technology itself has the characteristic of being a best-of-breed technology for the user teams who do the design when they create their own systems. But underneath, all of the systems created by different teams for different clinical specialties are all stored in an enterprise architecture. And so in the one installation, you have a single set of software for many specialty systems, but together their data is stored in the one location, and so everyone can see each other's design of the clinical system and can see their patient data, given of course they have appropriate permissions. There are two core principles. One is Occam's razor of design, which is published in a paper some years ago by us, which has the essential model from Occam's razor itself. One should not multiply entities without necessity. So here in Occam's razor of design, we say that you have to design in any particular design task a minimum number of objects to complete the design, but they are going to need to have their maximal generalization. And so you have to trade off between how many design objects you have in your design language or your design methodology and the functions of those design objects. The second part of our principles is agile design. So this is borrowed from the principle of agile programming, where an agile design is a design that evolves and is created by a team in a dynamic way, and it doesn't reach some sort of finite end. We believe that design goes on continually for clinical information systems, and so agile design is about both continuous design and dynamic design as the use of the system continues over a long time. Well, the principles are ensconced in a technology which has a number of core ingredients. Firstly, we designed a language which is a language for designing clinical information systems. Secondly, we built a GUI that's easy to use and enables expression of a design when working with our clinical partners. And thirdly, we have a mechanism for compiling the design directly into a runtime system. Hence, we remove all the need for programming between the process of creating a working design and a working system. I think firstly our current programming methods have reached the point where it can be done. That is, methods well grounded in the principles of software engineering and computer science. I think secondly, we are a fresh set of eyes, bringing in our own knowledge and new perspectives from other disciplines and experiences. And I think thirdly, we have this key belief that clinical staff should come first in any IT solutions, and that our role is to support them, not to dictate to them. The general problem we're trying to solve is the rigidity of work processes created in EMR systems as is common. We believe that there's in fact a need for continuous process improvement in clinical information systems. That is, the technology has to support evidence-based work processes and change management of those work processes. So this requires a number of functionalities in the software. You must have real-time changeability. You have to be able to change when you need to change. It has to have native interoperability. Systems have to be able to exchange data readily, easily, and in quite simple way. You also have to have native analytics. You can't afford to have to go and buy new processes for analytics or learn new processes for analytics. They need to be intrinsic into the software itself. And all of these need to be available in the context of clinical team-led design, where it's not just the users being centre of the design, they in fact lead the design. I think there are many benefits, and that in time they'll be shown to be highly valuable. First of all, clinical teams get control of their own IT solutions. Doesn't mean that they can run riot. They need support from people like ourselves who are experts in design and process analysis. But you certainly get better morale from them. They have a better understanding of their own systems, which helps them to understand the limits and how to use the technology optimally. I think also you've got better drivers to improve the use of EMR data, or what we call clinical information systems data, and that'll increase the value of the work that they do. For our own technology itself, it provides much faster development times, up to 10 times faster than what you would get from classical methods. You also get better professional training of the junior medical staff, and that we believe that the IT in fact controls the processes in a clinical department, and therefore it controls the training of the staff. And if you have a system that is designed to optimal work processes, you get optimal training of staff. Obviously it gives time savings in the conduct of work because it's better tailored to their work needs. And importantly, the IT no longer controls the process of work, but rather the needs of work, right, that dictate what the IT should be. Well, I think the key findings were that the technology we built was 40% more efficient and had 30% lower cognitive load than the enterprise EMR that's currently incumbent in the ward. But there are other features that were pretty important too, and that I think we were able to identify that best of breed is necessary to be used for the clinical settings, for the clinical specialties. But at the same time, enterprise capability is needed to aggregate records across different specialties. ISIM's emergent clinical information systems technology combines both of these in a new and an innovative way, and we're able to demonstrate that that was the fact. I think it's important to understand also that IT defines the nature of work processes in a clinical setting. People have to follow what the IT coerces them to do. And so the IT itself has to be capable of responding rapidly to changes in the dynamics of the clinical setting. And I think lastly, if we think about what might be the optimal return on investment for any health organisation, then the emergent clinical information systems technology that really is the coming way to do things, right? That is flexible, it's easy to change, it's inexpensive to change, it's got a much shorter development cycle. We know that development times, right? That, and in the end, it makes the staff happy and to use the IT, and that's a major barrier when people are not happy.